Hi, everyone, and welcome to the Otolaryngologic Clinics podcast series. I'm Taylor Hayes, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the June 2025 issue dedicated to laryngopharyngeal reflux. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, everyone. I'm Dr. Sujana Chandrasekhar, consulting editor of Otolaryngologic Clinics of North America. Today, I'm speaking with the guest editors of the June 2025 issue of Clinics, which is on laryngopharyngeal reflux, Drs. Ina Hussain and Nikki Johnston. Dr. Ina Hussain, MD, is adjunct professor of otolaryngology at the Indiana University School of Medicine and medical director of laryngology at Powers Health in Munster, Indiana, USA. Dr. Nikki Johnston, PhD, is professor in the Division of Laryngology and Professional Voice and Pediatric Otolaryngology in the departments of Otolaryngology and Communication Sciences and Microbiology and Immunology, and director of Airway, Digestive, and Voice Research at the Medical College of Wisconsin in Milwaukee, Wisconsin, USA. Welcome, Ina and Nikki.
Thank you. Thank you so much for having us.
Yes, thank you. Really appreciate the opportunity to join you both to discuss this Oto Clinics issue in LPR.
Thank you. Well, you've both put together a comprehensive issue of Clinics looking at LPRD, or laryngopharyngeal reflux disease, from every imaginable perspective in the 14 articles that you've included. I think it's a great resource for learners, researchers, and clinicians in otolaryngology, speech and language pathology, and also gastroenterology, surgery, medicine, and lifestyle medicine. So I think it really allows many types of clinicians who interact with patients to benefit. I really like that you've put a box with all of the abbreviations that you use at the beginning of each article. And I think that really levels the communication across the fields. So to our listeners, as you know, you can find all issues of Otolaryngologic Clinics of North America at www.oto.theclinics.com and in your institutional and maybe even personal library. And you can find all of our podcasts, which are one per issue since 2017, at our website or wherever you get your podcasts. I think you'll find that they are a great way to dive into a detailed subject in otolaryngology. So Ina and Nikki, let's highlight some of the many pearls in your issue. In the article by Savarino, Leshien, and Bertin, they discuss reflux versus reflux theory of LPRD. So Ina, Dr. Hussain, what is LPRD and what causes the symptoms?
So LPRD stands for Laryngopharyngeal Reflux Disease, and the easiest way to think about it is that it is the symptom, the upper aerodigestive tract symptom manifestation of what we traditionally know as reflux. And what gets a little bit more complicated about this, as discussed in that chapter, is that there is a reflux theory and a reflex theory. So the reflux theory is traditionally what we call laryngopharyngeal reflux, where that gastroduodenal reflux comes into the esophagus and then into the laryngopharynx, and with direct contact causes a lot of inflammation of those tissues, which then cause symptom manifestation. So the chronic throat clearing, mucus, globus, cough, all of those symptoms come from that direct tissue inflammation and damage. The second part of LPRD is really more of the neural mediated response. So we know gastroesophageal reflux can trigger upper aerodigestive tract symptoms through the vagus nerve. So without making direct contact, there are inherently built reflexes as protective mechanisms. And so patients can present with the same symptoms, but due to more indirect responsive reflux.
And then I think the authors included a really nice figure that sort of highlights this. Can you talk to us a little bit about that?
Yeah, so I think this figure helps break down what we mean really by reflux theory of LPRD, showing that kind of direct movement, direct tissue contact causing the inflammation and system and manifestation, and then also shows kind of indirect how reflux just in the esophagus can trigger those same symptoms through more of a vagally mediated response.
And just to follow up, would you approach treatment differently? I know we're going to talk more about treatment later, but as you divide these patients into maybe more reflux versus reflex, do you gear treatment differently?
Yes, I think that's why it's really nice to start with this chapter in this because we're also trying to level the field of what we're talking about with the reader, right? So classically, I think most clinical practices discuss LPRD as simply the LPR or the reflux, the direct mechanism, but it's very important to understand that there is an indirect mechanism as well. And until we have better diagnostic criteria and subtyping, to really truly create algorithms for these patients, it's important to remember that even addressing, direct tissue inflammation may not stop the symptoms if we don't address the vagally mediated responses.
I think that's really very helpful. So, just going on to causative factors, in the article that you wrote, Nikki, Dr. Johnston, with Samuels, you discuss the role of pepsin, mucosal injury, and non-acid reflux. And so why do you think pepsin might be the key for the symptoms of LPRD?
Yeah, so for a long time, LPR was thought of simply as an extension of GERD, so stomach acid moving higher up and irritating the throat. But what we've learned over the past 2 decades is that explanation is far too simplistic. Many patients with LPR symptoms don't have significant acid exposure and they remain symptomatic despite acid suppression therapy. And so our understanding has really shifted towards a new, more nuanced model that includes non-acid reflux, pepsin exposure, as Anna mentioned, neurohypersensitivity and impaired mucosal defenses. We now recognize LPRD as a heterogeneous disease with multiple phenotypes rather than a single entity. And so that evolution has really been critical because it explains why a one-size-fits-all treatment approach, so particularly the historic use of PPIs, has failed so many patients. Pepsin is increasingly...
And I'm just going to interrupt you. PPI means?
Sorry, proton pump inhibitors. Yeah, so pepsin is increasingly recognized as a central player in LPRD because it links reflux exposure to tissue inflammation, injury, and disease, even in the absence of acid, as shown in figures 1 through 4 in this chapter. Pepsin does remain stable at neutral pH, so as in non-acid reflux, and it can be reactivated inside cells after it's actually taken up by the laryngeal epithelium. And so this finding of pepsin uptake by laryngeal cells explains how pepsin can cause damage in non-acid reflux. And so the intracellular activity of pepsin disrupts cellular pathways, promotes inflammation, and impairs mucosal defenses. And importantly, this explains why acid suppression alone often fails. PPIs don't inactivate pepsin. So understanding pepsin's role, I think, has really fundamentally changed how we think about diagnosis and treatment, opening the door to targeted therapies aimed at blocking pepsin activity rather than just simply neutralizing acid. Table 1 summarizes the studies reported in the literature demonstrating efficacy of enzymatic inactivation of pepsin to attenuate all forms of experimentally induced peptic damage examined to date, so even in models of acid reflux. So in that regard, our team are excited to start enrollment for a 12-week randomized placebo-controlled double-blinded phase 2 trial to assess the efficacy of fosamaprevir, which is a pepsin inhibitor, for the treatment of PPI refractory LPR.
So I think in terms of symptoms, the patients cannot really express symptoms that will tell you this is acid-based or this is pepsin-based. So I think one of the things you just said is if they don't respond to proton pump inhibitors, maybe this is the way you think. Are there other clues that you use to think about not blindly just going for acid treatment?
Yeah, good question. So I think this is largely patients, like you said, that fail PPI therapy or have impedance testing that demonstrates that the reflux episodes that are actually getting proximal into laryngopharynx are in fact non-acidic, which I think is the vast majority of patients with LPR. And so, like acid, pepsin basically causes an inflammatory response, and it's that inflammation that is causing the symptoms. In our trial, we are assessing the presence of pepsin pre-treatment to see if it can be used to predict patients that would respond to a pepsin inhibitor. So our goal is to hopefully use that as a diagnostic again to identify which patients would benefit from this therapy.
Speaking of impedance monitoring, I'd like to talk to you about the article by Aoun, Umjuls, Eisendrath, and Leshian, which details 24-hour hypopharyngeal esophageal multi-channel intraluminal impedance pH monitoring, which is called HEMI-pH monitoring. Is this the gold standard diagnostic test for LPR? How does it work? How hard is it for a clinician to implement this into their practice?
So yes, the HEMI-pH is considered the gold standard for diagnosis of laryngopharyngeal reflux. So we are looking for that refluxate coming distally up the esophagus into the laryngopharynx. And so this is called a catheter-based reflux test, where a small catheter is placed through the nares into the pharynx, into the esophagus. It has both pH, an upper and lower pH sensor, and also impedance sensors throughout the catheter so that you can actually see that refluxate move upwards. And so you can see it distally, and then you can see it come up to the laryngopharynx, where we would call it an LPR event. This is considered the gold standard, and an article by Leshian and group IFOS Dubai 2024 kind of makes the criteria that if you have one of these reflux events, greater than one of these reflux events in 24 hours, then you would be diagnosed with LPR. Additional benefits of this testing is that there is the ability to do symptom correlation, which I think is also very important, right? Are you coughing because of reflux, or do you have two different things, reflux and a cough for some other reason? So the symptom correlation can be very helpful. The implementation of this into clinical practice, I would say, to be very frank, is not that difficult. The device itself has a cost, but it's significantly less than a lot of our otolaryngology procedures we are already doing. I think the main downsides to this is, one, patient comfort. Most people tolerate this, but again, when we're talking about LPRD and pharyngeal hypersensitivity, it can be sometimes challenging for patients to tolerate this. It also only looks at 24 hours, right? And so if someone doesn't happen to reflux, you may not catch it. The other downside to this is that it can be a little bit time consuming for the clinician who has to read the measurements afterwards. And unfortunately, reimbursement doesn't always correlate to the time spent doing it. So it can be challenging to incorporate this widespread in practices. I will say one of the other challenges, frankly speaking, is most places where you can find HEMI-pH, it is actually being offered by gastroenterologists. And again, as we know, this is not GERD. And so there is a certain amount of subjectivity when reading it in the context of the patient's symptoms. And so I, as a laryngologist, I do this in my practice because I treat a lot of patients with LPRD, and I encourage my colleagues to do so as well. It's something we can incorporate, and to be frank, we should.
So you would put it in the office and sort of tape it to them and tell them to go away, and then they come back tomorrow.
Yep.
Right? And you take it out?
Yep. So we place it as ENT, I place it under direct visualization of one of our flexible laryngoscopes, so I can see where the upper sensor is in terms of in the hypopharynx. In gastroenterology, GI offices, they actually do this with the placement of manometry, looking at the upper and lower sphincter. It's placed within less than 3-4 minutes. Patients go home, and then the next day they come back, and the nurse is able to easily remove the catheter, and then the physician or clinician can review the recording.
And then in this time, do you ask the patient to eat a normal diet? Do you ask them to sort of splurge and eat things that they know are going to, or they anticipate will cause their symptoms? Or do you, like in the old days, well before the two of you were born, and we were sending patients home with Holter monitors, there was this whole big thing about record every activity you're doing, and are you doing jumping jacks? Are you taking a walk? Are you sleeping? So do you have the patient change their regimen or do something so that you can actually prove it rather than have a bland diet that evening?
So one of the things that I like about this test is you can actually customize it for the patient. And I think a lot of with LPRD right now, because diagnostic criteria is in flux, our understanding is somewhat in flux, we have to be able to provide individualized medicine for patients. And that includes some of the testing as well, right? So if I have a patient who comes to me and they're on, let's say, acid suppression because of an indication, like let's say they had Barrett's and they want to stay on their PPI, but they're having breakthrough symptoms. I can do the pH impedance test for that patient, but I know ahead of time that they're on acid suppression. I have other patients who are on incredibly restricted diets, and they are like, I'm doing okay, but I really want to be able to eat X, Y, and Z. So I tell them, why don't you eat X, Y, and Z during this 24-hour period so that I can counsel you better? Because right now I have no evidence that that's actually triggering reflux. So it can be customized. There are some benchmarks that we use in terms of what is considered normal and abnormal, but the clinician has to put their input, right? You have to put in context of what the patient is saying. And so, yes, keeping a diary of symptoms, what you were eating, drinking is really important.
So, we had already discussed some of the reflex or the vagal mediated LPRD. So, Nikki, Dr. Johnston, Doctors Yapali and Bohr write about neural mediated LPRD and the role of esophageal dysmotility disorders. So can you talk to us a bit about the role of the vagus nerve in various symptom manifestations in patients who present with reflux?
So I think one of the key points that Dr. Yapali and Bohr make is that not all reflux symptoms are driven by physical injury from reflux reaching the larynx. In many patients, symptoms are actually mediated through neural pathways, and the vagus nerve plays a central role in that process. The vagus nerve is the main communication highway between the esophagus, the larynx, and the brain. And when reflux, whether that be acidic or non-acidic, stimulates the esophagus, those signals can be transmitted centrally and perceived as throat symptoms like globus, chronic cough, throat tightness, or voice change, even when there's little or no gastric material actually reaching the laryngopharynx. And this is nicely shown by the authors in Figure 1. What's especially important is in that some patients, these vaguely mediated pathways become hypersensitive. So the pathogenesis of neurogenic inflammation is shown in Figure 2. Once that happens, even minor stimuli like esophageal distension or brief reflux events can trigger exaggerated symptoms. Yapali and Bohr also discuss how esophageal dysmotility can amplify this process by prolonging exposure and increasing that sensory signaling. And they summarize the relevant studies in the literature on esophageal dysmotility in LPR in Table 1. I think clinically this helps explain why some patients continue to have symptoms despite minimal reflux burden or adequate acid suppression. In these cases, the problem isn't ongoing injury, it's altered sensory processing, and recognizing the vagus nerve's role allows us to shift the management approach away from simply just suppressing reflux but towards addressing neurosensitivity and esophageal function, I think, more broadly. Esophageal dysmotility impairs clearance of refluxate, increases the duration of exposure and the likelihood of that proximal migration. And so when combined with neurohypersensitivity, this creates a perfect storm for persistent symptoms. So I think this article highlights that treating reflux alone is insufficient for some patients, and addressing motility, sensory processing, and central reflux pathways become equally important.
And I think I'm glad you pointed out the figures, because I think they really are very illustrative and help us broaden our horizon from just the reflux to including the reflex. So you mentioned globus. So globus is a term used for the sensation of a lump or fullness in the throat without dysphagia, and it is a really challenging complaint. You both included an article by Kutrampakis and Richards that addresses this complaint in detail. So, Dr. Hussain, what role does the upper esophageal sphincter play in LPRD and in globus symptomatology?
I would say this is a fantastic chapter for any ENT that treats patients with globus, because this is a lot of information that we unfortunately are not routinely taught, but it plays such a big role in these patients. So when we think of the upper esophageal sphincter, I think part of this is so fascinating that there are internal protective mechanisms against reflux. So your body is trying to help you, right? And that's what the upper esophageal sphincter is trying to do. It's trying to protect that laryngopharynx, that sensitive upper airway, from exposure to refluxate, because all humans reflux. It is normal physiology. And so what we think happens in LPR, and sometimes it is a little bit of the chicken or the egg scenario, right? So what we think is with reflux events, there can develop a hypotonicity of that upper esophageal sphincter, which actually allows that refluxate to essentially escape, creating LPR events, which can then lead to LPRD in the direct mechanism. What's interesting, though, is oftentimes as ENTs or laryngologists, we actually see patients with the opposite problem. So we will see them for reflux events that have actually turned into hypertonicity of the upper esophageal sphincter, creating that kind of protective, overly protective response. And that can manifest as globus, or even more severely like a CP bar, and actual obstruction. So that upper sphincter definitely plays a role. Now, why do some people develop hypotonicity in response to reflux? I think that still needs to be worked out, but we do think that there is a barrier dysfunction that occurs to allow that refluxate to escape.
I happen to be an otologist, neurotologist, and I think we all in our subspecialties have one or two symptoms when a patient comes in, and it's very challenging because it's not an easy symptom to finding relationship. So I agree with you. I think that this article, and they titled it so funny, "What's with the lump in the throat?" Right? It's just a funny title, but very appropriate, because doc, I got a lump in my throat. Doc, I got sinus. Doc, I got, whatever. Like we all have some symptoms that people come in with. And this really allows you to approach that in a much more regimented fashion, I think. I'm Dr. Sujana Chandrasekhar. I'm the consulting editor of Otolaryngologic Clinics of North America. I'm really enjoying talking about laryngopharyngeal reflux disease today with the guest editors of the June 2025 issue of Clinics, Drs. Ina Hussain of Indiana University and Powers Health, and Dr. Nikki Johnston of the Medical College of Wisconsin. You can find all issues of Clinics at www.oto.theclinics.com. You can actually buy individual issues of Clinics, either hardbound copies or electronic, or both. And hopefully you can find them in your institutional and maybe even your personal library. You can find all of our podcasts, one per issue since 2017, at our website or wherever you get your podcasts. Please give them a listen. I really enjoy meeting these guest editors and learning more in detail in this manner, and I hope you enjoy listening to them. And tell your friends. And if you have any suggestions, I'm really, really happy to hear from you and make things better. So let's get back to the discussion. Nikki, Dr. Johnston, the article by Sims and Blumenstein addresses one of the major concerns of people with LPRD, which is their dysphonia or voice change. Why is it so challenging to manage hoarseness or other voice changes in people with LPRD?
Yeah, so dysphonia appears to be one of the most frustrating symptoms for patients with LPRD, and it's challenging because it's almost never caused by a single factor. As Sims and Blumenstein highlight, voice changes often reflects a combination of reflux exposure, mucosal inflammation, tissue vulnerability, and compensatory voice behaviors that develop over time. I think tools like the Reflux Symptom Index, the RSI, and the Reflux Finding Score, the RFS, are helpful when they're used thoughtfully. The RSI allows us to understand how much symptoms like hoarseness or throat clearing are affecting a patient's daily life, while the reflux finding score helps document laryngeal findings and monitor changes over time. Neither tool is diagnostic on its own, but together they can help guide longitudinal care, which is critical because voice symptoms often improve more slowly than other reflux complaints. Dietary management also plays a major role. Reducing exposure to acid and pepsin through diet can significantly limit ongoing injury to the laryngopharynx. As discussed in the management chapters, plant-based diets, low-acid diets, alkaline water, and nutraceutical approaches help reduce acid and inhibit pepsin activities. These strategies aren't just about reducing reflux events, but they're also about protecting that laryngeal tissue and supporting healing. So ultimately, managing dysphonia in LPRD requires patience and a multidisciplinary approach, voice therapy, dietary modification, and targeted reflux management.
So how cooperative do you think your patients are, Nikki, when you tell them, okay, now you got to stop with the soda, stop with the caffeine, stop with the all the other stuff that they're eating incorrectly? How enables patients to feel empowered?
So I'm a PhD. I don't see patients. I have a research lab, but I can imagine it's challenging. I do hear from, I think if you have to pay that much attention to what you eat or drink, I think it probably causes some anxiety, and I think that can be a vicious cycle with anxiety contributing to symptoms. But of course, these patients are highly motivated. So, I think if they can be guided through dietary management to help improve their symptoms, then they are highly motivated. And I'll let Ina contribute to how she manages these patients.
Yeah, I would say it's hard. I mean, as someone who has reflux and LPRD myself, I understand. I understand that giving up everything. I think sometimes we look for really that positive response. So kind of make a little agreement with patients of let's give it a try, right? We're not saying forever. How about we just do a couple of weeks and we try to, be intentional about our decisions and see what the response is. Because again, a lot of times during this first visit, it's a suspicion that reflux may be contributing. But again, if we're not seeing that response that we're hoping for, then we have to come back to the table and either do diagnostic testing or look for other etiologies. And I think with dysphonia, that's really important because even laryngologists doing video stroboscopy, sometimes we need to look at a larynx 2 or 3 times to really see what's there, right? We might be missing a subtle paresis and things like that could explain the patient's symptoms instead of reflux.
Thank you. So, Ina, you and I got to know each other a while ago because I was just enamored by your social media posts. And I was like, hey, I'm meeting you in person. I very distinctly remember fangirling you at the American Academy of Otolaryngology meeting in Los Angeles a few years ago. And I thought, this is the greatest way because I think this flows right into it, right? Doctors tell patients all sorts of things, but until we can explain it in a way that actually makes sense, it's very difficult and sort of unreasonable, I think, for us to expect our patients to follow advice that may be challenging to follow. Your social media videos just get right to the point. And I think one of the things you've addressed is chronic cough. You included in this issue of Clinics an article by Jaworek and Carroll looking at chronic cough and other pulmonary manifestations of LPRD. So can you explain to us how reflux contributes to chronic cough?
Yeah, so I would say this is another fantastic chapter for anyone who sees patients with chronic cough. Sometimes knowing that it's connected to reflux, that's not the hard part. It's kind of really understanding and explaining to patients. So the simplest way, essentially, that we think reflux contributes to chronic cough is through really that direct tissue damage, that microaspirate of reflux. And there's a great figure in here that kind of shows how essentially, it's figure 1, shows how essentially it's a failure of multiple barriers here, protective barriers that create this microaspirate that then makes direct tissue contact contact with the lungs. And that inflammation can even lead to things like fibrosis. And so we think it might play a role in some of those really difficult conditions, like idiopathic pulmonary fibrosis. What's also interesting with chronic cough, though, is that even without direct tissue damage, the tracheobronchial esophageal reflux could trigger a lot of coughing in patients as well. And so I think that's why diagnostic testing is so important, to really see if that reflux, say, is making its way into the laryngopharynx and we think it's direct tissue damage, versus is it just that vaguely mediated response that's happening and that's causing the chronic cough, which we would then treat more like neurogenic chronic cough.
I like that figure very much. And I think later on in figure 2, they have these incredible SPECT CTs that are pre and post interventions.
This is really fascinating too. And I think, you learn things also editing some of these chapters, right? And so, yeah, this is a great figure that shows pre and post-op fundoplication and using kind of SPECT PET CT to see how there's a reduction in the exposure of the laryngopharynx and the lungs to refluxate. And so you can see that reflux surgery interventions can actually reduce that. And so that's, a really fascinating image here that they have.
I know that we've covered a little bit of the esophagus, and we've certainly covered some pulmonary issues, but most of the time, as otolaryngologists, as speech and language pathologists, we talk about LPRD as if it's just limited to the larynx and pharynx. And that doesn't really seem to be true, as seen in the article by Dr. Allen. So, Nikki, Dr. Johnston, what are the manifestations when LPRD extends past the laryngopharynx? And I guess by past, I mean superior to the laryngopharynx.
Yeah, so as Dr. Allen nicely summarizes, LPRD can affect multiple organ systems, including the middle ear, the nasal cavity, and even the lungs. Pepsin, a specific biomarker for reflux and aspiration, has been identified in all of these sites in the aerodigestive tract. I'm really excited about, Dr. Hussain mentioned its role in sort of in lung fibrosis. My team are working with Dr. Nirmal Sharma at Baylor College of Medicine, and we're assessing the efficacy of fossamprevir to prevent pepsin aspirated injury and progressive lung disease. But I think recognizing that such extraesophageal manifestations really enforces the need for that interdisciplinary care.
As I was preparing, reading the issue again for this podcast, I realized that a patient had come in that morning, last week or the week before, and had sort of been in the queue for eustachian tube balloon dilatation, had chronic eustachian tube dilatory dysfunction, and had also had symptoms of LPRD. So he had seen my colleague and had actually followed the diet, had done all the things that we're talking about, and actually got himself off the list. And he was so proud of himself. He said, "Oh, I took all these airplane flights and I did really well," and so on and so forth. So I think not functioning in silos really helps. So as an otologist, it is important. It's imperative that I know about this, right? As a laryngologist, it's imperative that you know about the otologic manifestation. So I think these are really interesting, even within our field. And certainly as I began this podcast, I talked about the fact that gastroenterologists, internists, pulmonary medicine doctors can all benefit from this compilation of articles that you've put together here. We know that people use over-the-counter antacids a lot. There are, people just seem to be chewing them up by the handfuls quite frequently. And we also know that alginates are the latest, maybe they're a trend, maybe they're correct, maybe they're whatever, but they're very popular right now. So Inna, how do you counsel people about over-the-counter agents and diet in the management of LPRD?
Sure. So I like to try to get a sense of where the patient is at and what they're looking for. Because we definitely have the patient that truly is just coming in to make sure just wanted to make sure I didn't have a cancer, right? Like just a throat cancer type of thing versus the patient who is devastated by these symptoms. And I don't say that lightly, but simply not eating anything, not doing anything because of the fear of everything. And so I think trying to get a sense of where the patient's at and where we can meet them is really important. I do like to do the kind of like my version of an elimination diet, if you will. So if patients come in and they seem to be in what we call a flare, where there's kind of symptoms just continuously, whether it's throat clearing, mucus, globus, we really talk about trying the natural route first in terms of diet and lifestyle and giving a time limit on it. So make it a little bit more realistic for patients. I think a lot of patients who come to see me, mostly it's a second or third opinion, frankly. And by then they have either already tried acid suppression, whether it be over the counter or prescription strength, or they're coming in because they have read about the effects of chronic acid suppression and they're not really on board with that. And so we really talk to patients about, ways to naturally reduce reflux in terms of its mechanical processes, and then the use of alginate. And so alginates have actually been around for quite a while. They do have a lot of evidence that support them. And so, they not only help reduce mechanical reflux or reflux out of the stomach, they actually protect the esophageal lining. And so some of these vagally mediated responses we're talking about, by helping to create a barrier in the esophagus, we're likely helping some of those symptoms as well. And so they do have kind of a dual benefit, plus the fact that they're, as natural as you can get without reducing any sort of acid suppression. They can be used in anybody, essentially, pregnant women, children. So I think it's really popular because patients come looking for something like that.
In this article that you included by Dr. Daniero, I just want to read through for our listeners sort of the list of dietary modifications. And once I'm done, if you want to opine on it, I'd be very happy to hear about it. So they talk about dietary modifications for a reflux friendly diet. This includes increasing the intake of low acid fruits such as bananas, melons, and pears, incorporating high fiber foods like oatmeal, whole grains, and cooked vegetables, limiting high osmolality drinks with high sugar content such as sports beverages or fruit juices, opting for lean protein sources such as chicken, fish, or tofu, to reduce the fat intake with other protein sources, avoiding late night meals, maintaining an upright posture after eating, avoiding carbonated beverages, including flavored water and seltzers, and incorporating alkaline water for hydration. And that's really a pH of about 8.8. In the hierarchy of things like this, what do you tell your patients is really important?
Sure. So I actually individualize this based on the symptoms of LPRD that they are presenting with. I am a big supporter of doing some sort of diagnostic testing because we know there are a lot of different things that can cause mechanical reflux, right? And so if patients are presenting with kind of what typically feels like more laryngeal hypersensitivity symptoms, then I definitely focus more on the acidic low acid type of diets, not really from a reflux perspective, but on a direct tissue contact. And so for those patients, I'll say, let's limit the, highly acidic foods so that they don't touch your throat. In other patients where I feel like this is more actual mechanical reflux, whether they have a hiatal hernia, we'll really focus on portion sizes, right? So we'll focus on smaller portion sizes throughout the day, not eating close to dinner. Most actual LPRD is actually a daytime upright event, but a lot of patients present with us actually have traditional GERD type of symptoms that are not actively being managed either. And so I'll focus on portion control for those patients where I think it's more of a volume type of reflux happening. The guidelines that are listed are commonly what we give patients kind of as a guide, because again, when first time we meet a patient, we probably suspect reflux, but we have no diagnostic testing to support it. And so it's very difficult to customize advice if you have no data to go by. And so we give patients a guideline, but I think the important thing about that is don't just let them leave and never come back. Because that list, it's not sustainable for most people. Okay, and that's the reality of it. Yes, if most of us could abide by all of those restrictions, we probably would feel better. But most of the patients I meet, and this is across all different age groups and backgrounds, that is very difficult to sustain for your whole life. And so, initial visit, yes, these are some guides while we're doing some further diagnostic testing for you.
Yeah, I like that a lot. So as we wrap up this discussion, let's have you turn on your crystal ball. So Dr. Leshian wrote the article looking at future trends in LPRD. So Nikki, Dr. Johnston, what is next for diagnosing and treating LPRD? And then I'm just going to throw in a little kicker. It seems like half the world is on GLP-1 inhibitor medication. So how is that that's limits gastric emptying, it slows down gastric motility. So how is that going to affect how we manage our patients or view our patients in the future?
Yeah, so I mean, first of all, I agree with Dr. Leshen that the future of LPRD is precision-based rather than symptom-based. In his chapter, he emphasizes that we're moving away from empiric treatment and towards better phenotyping of patients, understanding why someone has symptoms rather than simply labeling them with the LPRD and treating with a PPI. From a diagnostic standpoint, that means greater use of objective tools like the impedance pH monitoring that we discussed, refined symptom indices, and emerging biomarkers to identify distinct reflux phenotypes. He also highlights the importance of recognizing neural-mediated disease and hypersensitivity, which helps explain the traditional acid suppression therapy, why that has had such inconsistent results. I think therapeutically, the future just isn't stronger acid suppression. It's more of a mechanism-targeted treatment, which, as we've discussed, includes alginates, dietary strategies, pepsin-focused therapeutics, neuromodulators, and individualized behavioral interventions. Regarding the GLP-1 inhibitor use and how that affects this condition, this is an evolving and a really important area. GLP-1 receptor antagonists, as you mentioned, are used widely now for weight loss and metabolic disease, and clearly have the potential to influx reflux physiology. By slowing gastric emptying, these medications increase gastric distension and in some patients worsen reflux symptoms, particularly early in treatment. But at the same time, longer term weight loss may ultimately reduce reflux burden in certain patients. So the effect isn't uniform. I think what's critical is recognizing that GLP-1 use may change a patient's reflux phenotype. So for someone with LPRD symptoms, especially dysphonia or cough, one needs to consider whether delayed gastric emptying or increased non-acid reflux could be contributing. And I think this reinforces Dr. Leshen's point that the future of LPRD management must account for those systemic factors and comorbidities, not just acid exposure. As GLP-1 use expands, reflux evaluation and counseling will need to be more nuanced and individualized.
Thank you. Any final words from you, Ina, Dr. Hussain?
No, I'd just like to thank you for giving the opportunity for us to put this text together. I think it was very much needed, and the feedback we've received has also been very positive with it. So I hope it gets, our colleagues thinking about reflux in a very different way. And, it's not outside the realm of ENT to take a hold of this because it does have so many symptom manifestations that we primarily treat.
Well, I want to thank you both so much for your time and energy compiling and editing this issue, picking great guest authors, and then doing this podcast with me. It has been a joy speaking with the guest editors of the June 2025 Otolaryngologic Clinics of North America on Laryngopharyngeal Reflux. Dr. Ina Hussain, MD, is adjunct professor of otolaryngology at the Indiana University School of Medicine and medical director of laryngology at Powers Health in Munster, Indiana, USA. Dr. Nikki Johnston, PhD, is professor in the Division of Laryngology and Professional Voice and Pediatric Otolaryngology in the departments of Otolaryngology and Communication Sciences and Microbiology and Immunology, and Director of Airway, Digestive, and Voice Research at the Medical College of Wisconsin in Milwaukee, Wisconsin, USA. As I've said, you can find this and all the podcasts that we have recorded since 2017 at www.oto.theclinics.com, and you can find all present and past issues there as well. I hope your institutional and/or personal library has issues as well. I'm Dr. Sujana Chandrasekhar. I'm consulting editor of Clinics, and I'm really glad I was able to talk with our guest editors and spend this time with you. Thank you both so much.
Thank you for joining us today for this edition of Otolaryngologic Clinics podcast series. For an exclusive discount on the issue we discussed today, please visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on LinkedIn and subscribe to the Otolaryngologic Clinics podcast wherever you get your podcasts. Thanks for listening.